Welcome to Vet Wrap. Welcome back. I'm Arthur, and today I'm joined by Jess Austin. I had to remember that. Our referral nurse team leader, who is now done this before. Very experienced at podcasting. Awesome. And today, what are we talking about, Jess?
We are going to be talking about, what are we going to be talking about, Arthur?
Okay, minimising medical error in the surgical team. So I get a bit excited about this, Jess, so you're going to have to say time out when I get
Cut
super distracted.
Yeah, no worries.
So why is talking about medical error so important? It's just basically a nightmare, isn't it?
Yeah,
so,
it's a disaster.
Yeah, for patient, for
client,
and
for us.
Vets involved, yeah.
Yep.
It's misery because we know something's gone wrong. And one thing I really wanted to touch on is sources of medical error and how we perceive medical error. So I guess it's a little bit common, unfortunately, to say something went wrong, you did something bad as an individual, and that's 100% incorrect and not the way to think about medical error, because it's being really nicely demonstrated that medical error is very rarely an individual's mistake, if that makes sense. It's often a whole lot of very small mishaps that lead to a medical error occurring. And there's lots of different models. But before we talk about medical error as a concept, we probably should talk about how does an individual make a mistake. And ultimately, there's sort of three levels. There's an error at a level of the skill, which is a mishap. Oops, I cut the aorta. That's not good, of course. And that can actually happen to anyone, and that's skill-based. Then there's a rule-based type errors, which is where you apply the wrong rule to the situation. And actually, believe it or not, the more experienced and the more expert you are, the more likely you are to make a rule-based error, because you have a tendency to pattern spot because you've seen something so many times.
Really, hey?
It's because you've seen like so many, you see a certain pattern, you go, oh, that's going to be this. Whereas a younger clinician tends to do a problem-orientated approach and they work through the problem list. So they tend to be more likely to apply the right rule. Now I can have a go at the young person. They tend to have knowledge-based errors because they don't have the knowledge base of the old fart like me, but they're more systematic in their approach.
Yeah.
So that's how you do it on a personal level. But what I said before is actually, medical error is not just you or me as individuals. It's about a whole series of events that then end up with a negative outcome. Yeah. What's really cool is the history. So everybody knows about most people know about checklists, which we'll get to. And actually, the concept of error management came from
the aviation
industry.
Yep.
And checklists. And actually, I'm told that the B-52 bomber in the Second World War was where it all started. So the Americans made this really quite sophisticated aircraft, and they put pilots in it. And initially, a pilot basically got in a plane and flew off. But because the plane had become quite sophisticated, it quickly became apparent that the pilots were making errors and crashing these planes because they were missing vital steps in the process of taking off or landing.
And we couldn't rely on the brain to be able to...
Couldn't rely on an individual. So let's keep talking about that thing. Yeah. You can't rely on an individual to always think about all aspects of taking off a plane or landing it, or patient care, to always get it right.
Yes.
So let's stop blaming ourselves and start talking about how do we get a team right and aligned appropriately so that we can reduce error together rather than expecting an individual.
Correct.
Yeah. And our circumstance is that we have a high volume surgical service and we have a high volume of staff. And that's really where this concept, is highlighted, because we have to coordinate all the different people in the process. So in that very old-fashioned, hope that didn't upset anyone out there, but what was going to lead on, that very classical relationship of I'm a vet with my nurse, and together we work as a team of two, and we work from the beginning of the treatment process all the way through to the end, and then we start the next patient. Your chance of error is a lot less, of course, because it's just the two of you. But as that team expands and the workflow increases, your chance of error is going to increase.
Yeah.
Yeah. So when we talk about error as a group, one of the models is called the Swiss cheese model. And essentially the idea is you've got Swiss cheese, we've got holes in it, and there's pieces of Swiss cheese all in a line. And if you turn the pieces of cheese, eventually all the holes will line up across all the different slices. And that's this idea of lots of little things ultimately line, and boom, bad stuff happens. The other sort of modelling that's done is called the herringbone model. And the herringbone model essentially looks like the spine of a fish. You've got the central vertebra and you've got little spines coming off. And you then put on each spine every aspect that contributes to a negative outcome. Now, here's a really nasty thought. So there's every year about 50 people die from intrathecal injection of Vinchristine.
Damn.
And you die really slowly because your spine rots and you're going to die.
Yep.
But you don't die quick enough, so you get time to think about it. And essentially it's part of some therapy for some neoplastic disease. I don't quite know how that fits in. But anyway, they've modelled how on earth could someone stick Vinchristine into someone's spine? You'd think that's just couldn't happen. And it's all things like patients turning up late to their appointment.
Yep.
Because that puts the team under pressure to brush through the day. A junior surgeon being on that day, not the senior surgeon, who's not familiar with the processes, failing to go through the appropriate checklist.
Yep.
And there's about 15 aspects that all come into it, and things that you and I wouldn't normally think about, like being late for an appointment. Never be late for a doctor's appointment if you're properly sick, by the way, because that adds to error. There you go.
There you go.
And failure of communication between clinicians. So, yeah, we have to think of it, really quite broadly. So that was me waffling. You didn't time me out.
I was thinking about it and I was like, all right, let's move on, buddy.
All right, rock and roll. Close the laptop. We don't need that anymore. Done. All right, so what do we do? And we've broken it. We had a little chat before this. We planned.
We have planned.
We actually tried to do
ready.
this. We tried to do this podcast last week and it was a disaster. Here we are again. And we actually sort of recognise that the three big areas that we've addressed is communication, because we know that transfer of patients from clinician to clinician done badly or not in a structured way. Let's never say bad or good again, or you're a bad person again. It's not like that. So if it's not done in a structured way, that's an opportunity for medical error. And then we're going to talk about checklists because they are pivotal to decreasing medical error, and then about empowering staff, which sounds all a bit warm and fuzzy, but it's actually really important. So the whole issue around communication is you need to have a structured system that allows the entire team to understand the expected management process for that individual patient. Yep.
Correct.
And so that ultimately means it doesn't rely on the attending clinician, the clinician whose case it is, to have to repeatedly communicate to lots of different individuals what's going to happen. There's a reference point that everyone can go to.
Yes.
And we all understand why we're here. So we do that through, and over here's our admission form.
We have an admission form, which will come up nicely on your screen.
Yep, we'll project it. And ultimately, all of us in the medical world have an admission form, don't we? Basically, we're going to do this to your dog. This might go wrong. We add in, do you want CPR? Expectation around costs and all the rest of it.
Going through your complications, things like that.
And in a way, that's the beginning of reducing medical error by talking
just
about
having that conversation.
Yeah. What might go wrong?
Yeah.
Because it actually focuses.
Preparing the owners as well that this could happen.
Yeah, because you can't do surgery without potential for not only error but complication. But if the attending clinician, the clinician responsible for the patient, has to talk about that, that actually starts the process of thinking about how can we mitigate risk. Yeah. But more importantly for the team is the admission form. And really, what do we focus on there, Jess?
So here we have our patient admission form, which will have our TPR that the nurse or the vet, either or, will perform, the procedure, the location that we're doing. That's also super important. So we know what procedure we're doing and we know the location as to what area we're doing that procedure on.
Left and right leg.
Lefts and rights. We also have on ours what previous medication the patient has been on before. So whether it's been previously on a meloxicam, for example, a non-steroidal, so that we know the correct dose to give. as well as pre-medication. And then from there on our little list, we go into whether we need an IV catheter, whether we need what induction agent we might want to use, fluid therapy, going through any blood work, antibiotics, any pain relief, CRIs, or regional anaesthesia. And then also going into what kind of imaging are we going to be doing? Are we doing our X-rays, CT? Are we doing fluoroscopy? Making sure that we have all of those kind of things down pat. And then from there, we're going into what equipment we need. So what kind of kit is required for these procedures so that we also can reduce the need to walking in and out of theatre to try and go grab things.
Yeah.
And then if we are needing to do any sampling, so histopathology or anything like that, that's all on our admission form.
Yeah. And isn't it sort of interesting that superficially all that sheet of paper looks like is, an efficiency sheet. Okay, this is the work we have to do to go, guys, let's get the work done. But actually it's not, is it? Because it's if you are, one of the nursing team involved in this patient and myself as the attending clinician starts doing an ultrasound and you're like, but Arthur, why are you doing an ultrasound? Because you admitted this dog for a CT, you may well have just stop me at the right moment.
Yeah, before you go
hang
and
on a sec, is this George the dog or is this Charlie the dog?
Wise.
Well, something's happened, hasn't it? So
we've caught you before.
That's right.
You move forward.
Yeah. So there is this real crossover though between minimising medical error and actually it helps you build efficiency because it creates this opportunity to engage the entire team in a process and it really defines
and helps
the expectations.
Having everything ready, it also really prepares for that back-to-back kind of surgery that we'll talk about later.
Yeah. We also communicate. So effective communication is absolutely key. Not only do we have admission sheets, our other communication system is surgical rounds, yeah?
Correct.
So we schedule into our day. And again, structure. It's not maybe, it's this will happen at 9:30 to 9:45.
Yeah.
It's like admission sheets are a non-negotiable. It's a structure. It has to be in place.
So it helps set up our day with how we're going to
so what are we trying to do at those
So really we're trying
rounds?
to allocate the appropriate team to, let's say, a surgeon, for example. We do have multiple surgeons within our facility running a department as well.
Yeah. So there's another part of medical error that's been well studied is your physical resource. So error can be, it is tightly intertwined with the resources that you have in your hospital. And so that's not just, I don't have a fancy type of scalpel, that's also workforce as well. And so those rounds, we often have this, don't we? We've got a sequence of surgeries we've got to do and we have to acknowledge, okay, we have like what equipment is required. So if we need CT or if we need X-ray, like what procedure equipment is required for it. And the classic would be we haven't done those rounds. We go in, we make an approach to a fracture and it's like, we don't have a plate. Yeah. Like what a nightmare that would be. Not that we've done that, but that's how we're stopping sort of what seems so like... You're starting it before it actually begins. Yeah. And imagine being the client, hello, Mrs. Jones, I've cut open Fluffy and we didn't have a plate. Like you just would never get that, would you? No. How on earth did you do that? But actually, lots of things happened before you got to that point. Correct. That's such an important aspect. Yeah, exactly. Yeah. Anyway, so that's sort of the two key... I guess structures we've put in place to enforce appropriate communication across the team. But we're not just having communication from vet to nursing team, we're actually having communication between vets, so resource allocation. Yep. If we have a complex case and we're looking for an opinion, that helps us have the discussions between clinicians as well. Mm-hmm. And if we have to transfer a patient, this outside surgery, but if we transfer a patient from one discipline to another, we also have a similar checklist that is handed with the patient from clinician to clinician. Yeah. Awesome. Okay. Our second step is checklists. Now, I started waffling about B-52s and didn't finish the story,
industry.
did I?
No, you didn't.
So what happened? They were crashing planes. That was bad. What did they do?
They initiated a checklist. Yep.
You know, you see it in Hollywood, you know, that like flaps down, click, you know, break off, click, check,
Yep.
blah, blah. It's actually really cool being in a cockpit in a big plane. See, I'm old enough. I've been allowed to sit up there.
Oh,
I've actually sat in a cockpit of a big ass jumbo because I was transporting horses from Perth to Melbourne, and on the way back they let me sit in the front if we landed it. It was cool.
That would be cool.
It's really cool.
Yeah.
Geez, I get distracted easy. Yeah. Yeah. But they did the checklist, getting back on track.
Is this where it all came from? You just went one day and was like, we're doing checklists.
No. I was a really young vet then. I just was happy that I got home alive and the horse hadn't jumped out the side of the plane, which is why I was there.
Okay.
Yep. Big job. Anyway, checklist. So what do we do? What does ours look like? Because there's quite a lot of bits to this.
There is. So the reason why we have brought in checklists is to try and reduce, once again, medical error. That's our primary thing, and to reduce the load on the brain as well. So
hang on. Mm-hmm. And by that you mean stop it being all the responsibility of the single individual person, and make it the responsibility of the team.
Because why not have everyone involved?
Yeah. What is it? More brains is better than one.
Yeah.
All right. But it's not just a single checklist, is it?
No, this is in multiple stations throughout our stages of anaesthesia that's involved. So this is preparing your induction station, for example, and that involves, for our process, let's say we're taking x-rays and we're inducing the patient, that involves, has our consent form being signed? So do we know we have consent to be able to do this procedure? And then also
for what?
And for what procedure?
Are we actually supposed to be an x-ray?
Yeah. Are we meant to be here? What are we doing? And that comes down to, we're confirming our patient details. We are confirming the procedure that we're doing. Is the patient a CPR or DNR? Like, that is incredibly helpful to have that information.
Well, I hope we don't need it, but yeah.
But, you know, for the time that you said the what if.
Yeah, the what if, that's what we're planning for. Yeah.
And then also we have our CPR blood work that we've done to make sure we've had all of that information. And then we go into that more anaesthesia process. So our ASA status, so that's grading your patient from 1 to 5. We can go into a bit detail another time. And then also confirming what surgery site we are doing. So are we doing a left leg? Are we doing a right leg? Are we doing a front leg? Are we doing a hind leg? All that kind of stuff. And whether we have any secondary surgery sites. So if you've got this random lump removal you need to take off as well. And then also whether we're doing any other imaging scopes. If we're doing x-ray or if we're doing CTs or like anything else scope, anything else imaging related. That's what I was saying there.
You know what I like about that part, because you're going to tell people that we do it at different stages. You already said that. Isn't it cool how the chaos of vet life, a busy hospital, and then it's like this calm. So this is Fluffy. It's here for radiographs. It's the left knee. This is the procedure's going to do. And it's sort of like...
It's just a moment of just taking it all in.
And you just go, yep, that's right. That's the conversation I had with the owner. Yes, this is what we're doing. Engage, headspace, off you go.
Just
it's
in
awesome.
the moment.
That is that. Mm-hmm. I mean, it sort of feels weird the first time you do it because it's like
you're like kind of like, why are we doing this?
Well, but it feels like you're play acting, doesn't it?
Yeah, it does. Yeah.
And
we're
then
doing
you're
a little role play.
Yeah, it is a role play. But you know what? And it's. But isn't that cool for the nurse too? Because it's like, yes, I'm actually asking you, Dr. House, you know, have you got the right patient? Are we doing the right thing? Mm-hmm. Yeah.
Exactly.
It's very cool. Anyway, I'd love to interrupt.
Then we go into ensuring that our anaesthesia station is ready to go, because the last thing we want is to know that a part of our anaesthesia machine is not working, and then we get all flustered. We're just like, why is something happening? And what I don't know how to fix this kind of thing. If you've done all this beforehand, you're ruling out one of the biggest actual steps in your day, because it's the most frustrating thing to try and sit there and figure out what's going on.
But you can think when you're not under pressure.
Not under pressure. Yeah. Exactly. And then so that goes through for us. It goes through our induction equipment ready. That's including a laryngoscope. The amount of times that we're wandering around being like, where's the laryngoscope? If you have it already beforehand, we won't need it. We need it, sorry.
But you're not going to be in a crisis,
exactly, to find it. And then our anaesthesia circuit, have we leak checked it? Have we made sure that APL valve is open, not closed? And then also just making sure that all our monitoring equipment is good to go. Have we made sure we've got batteries that are appropriate for that machine, and that we have no broken or chewed equipment or anything like that we're like, oh, I forgot to check that before. I am not ready.
Isn't it interesting that anaesthesia is so much like the plane? Mm-hmm. You know, you forget to put the wheels down, 500 people die. Yeah.
Exactly.
More intense than us. Yeah. but you forget to open the AP valve, and a patient dies.
Patient death.
Exactly. Yeah, that's one really small step in the entire process of successfully managing an anaesthesia.
Exactly. Yeah.
And yet putting the wheels down is one really small step in flying pain from Perth to Melbourne.
To be able to survive.
Yeah. So you can see how the idea from the aviation industry just translated beautifully into medicine.
Everything really, isn't it?
Yeah.
Then we go into our prep. So we have moved our patient from X-ray to our prep station, and then we are now doing another check to be like, are we clipping the correct leg? Have we got the right one?
Love that one. There's no vet in the world who can't admit that that's happened to them, the wrong leg clip. Yeah.
And it's because we're just in such a rush to move the patient from one station to another that we forget what side have we placed it down on, and the surgeon's going, hey, let's go, let's move quickly, or the head nurse is like, hey, come on, let's move faster.
Well, but also when a dog's lying on its side, you have to hold your hands in the air to work out if there's a left side or right side.
You're doing your left
That's
and
right.
then your right, and you're just looking like a bit of an idiot.
So there's one more checklist.
There's one more checklist.
Yeah.
And this one is we're moving our patient to theatre, and we're going to be doing our before skin incision checklist. Yeah. And that involves a lot of people, so all the people in the room.
Yeah.
Yeah.
This is one I like the most because this is your time space. Yeah. Time out before we cut.
Yeah. So here we are, once again, we're confirming our patient identity. We're making sure that we've got the correct procedure that we're doing. So we're confirming our left and right leg. And then we also make sure our surgical equipment is sterile. So that's coming from your theatre nurse.
Yeah.
So that is making sure that all the equipment they are opening hasn't been sterilised. Is this appropriate? And then it comes to the anaesthesia nurse speaking to the vet, and they're going, I've given all of my medication that I need for this patient. Yeah. I have done the final skin prep, and then we make sure we communicate that with our theatre nurse. The theatre nurse, you've done the final skin prep. Awesome. Yeah. And then that also means that anaesthetic nurse can tell you how the anaesthesia is going and whether it's stable or whether you need to troubleshoot it a little bit. Yeah. But the one biggest thing that I find with this before skin insertion checklist is that it actually comes from that anaesthesia nurse, not coming from the vet telling the nurse what the patient is, what's required. So then it really gives that nurse a bit of a voice to know that.
What I want to say is empowering the team around you to speak up.
Yep.
Yeah. But everything we've talked about, from the admission form and surgical rounds, at the beginning of the day, now these checklists, that's the key, isn't it? It's like the whole team has a system to know what's expected for the treatment of the patient, and they have it allows them to be confident enough, empowered, to say, what's going on when you're not on track. This was not what we were, this is not what had been planned for this patient. There's an issue.
Yeah.
The other thing is just listening to you talk about those checklists. It's amazing, isn't it? Because the number of things that need to be considered, it is such a long list.
Imagine the brain trying to remember all of that.
I actually was just like, how did we do this? Before. How did I carry that burden before I actually worked in a team? Because I've worked in plenty of teams where we just didn't have systems in place. We just, it wasn't a structured part of the day that our admission sheets had to be so detailed that we did do rounds to coordinate days and checklists at several steps along the way.
Yeah, and what we found is that we're almost like relieved as we're doing this checklist, right?
Yeah.
Because we're just like, okay, we definitely have gone through all the things that we need, and everyone's on track, everyone's on board.
But it's like the expectation of a single individual can carry that responsibility is just ludicrous. Yeah. Like it's not possible. So they are absolutely spot on.
Yeah.
Now, you done with that one?
No, we're not done yet.
You really want to keep going?
Still going.
Okay.
Only just the last little bit is a recovery checklist.
Oh yeah.
And that last bit is making sure that we have done a bladder check,
Yeah.
making sure all of our equipment is taken off our patient, and if it requires a dressing, pathology has been handed to your vet, because, last thing you need is that pathology sample is not labelled.
Well, or doesn't go.
Or doesn't go.
That's awful.
And whether the patient needs patient warming post-anaesthesia. And that's another thing, just to make sure that you sit there and you go, yep, I've done that, we're prepared, we're good to go.
Yeah.
Yeah, and that's checklists for you.
And to all those listeners out there, if you want copies of our checklists and admission forms, then, reach out. We're always happy to share this, because ultimately, anything that we can do to minimise medical error across the profession, well, we're going to want to be involved. That'd be awesome. Empowering staff. So the last thing, because we always run over time, so we've got to move along, but we have very again, it's very structured, but we have in the nursing team nurses on different shifts.
Yeah.
And so we define each shift really tightly. Yeah.
Yeah.
Yeah. So our shifts are.
So we have a hospital nurse.
Yep.
So that hospital nurse is the one that attends to your patients first thing in the morning that have stayed overnight.
Yeah.
And then they're also your recovery nurse.
Yeah.
So they recover all of your anaesthetic cases.
Yeah.
Then we have our anaesthesia nurse, and then we have a theatre nurse.
Yeah.
Yeah.
And in order to allow each individual to understand their role in the process, because essentially a patient is admitted by the primary attending clinician. Mm-hmm. It will go to the hospital nurse to coordinate its hospitalisation. It will be the skin prep and taking radiographs will be the anaesthesia nurse and the theatre nurse.
Yep.
The induction process and anaesthesia monitoring will be vet and anaesthesia nurse.
Yep.
Yeah. So essentially, a patient will always have, as a minimum, a team of 4 individuals, often 5 or 6. Mm-hmm. So we put in place those very tight descriptions of what the responsibilities are for each shift, which allowed people to fully understand how they were going to contribute to the management and the successful treatment of the individual patient. But isn't it, we sort of did that 2 ways, because people know what they need to do, therefore we can ask them to do the job they need to do. But the main motivation is so that those individuals are empowered to understand how they're going to contribute to the patient care. So it's sort of like an extension of everything we've said, isn't it?
Exactly.
Yeah. Clearly defining each person's role is an essential part of minimising medical error.
Exactly.
Yeah.
And then the handover process.
So
once we've done our case, then that's a conversation between our anaesthesia/vet to the recovery nurse.
Yeah, so that's not so much in how we define each role, but that comes back to, recognising part of medical error can be in that transfer of patient from clinician to clinician.
How much is that Chinese whispers sometimes?
Yeah, that's right. And so we don't have quite as formal a structure around that, but we do it through the hospital flowcharts, don't we?
Correct.
So a requirement is the patient comes out of surgery and the hospital flowchart is completed, and then as that patient's transferred from the theatre team, so anaesthesia and theatre nurse and surgeon, to the hospital team, the hospital nurse, that flowchart
that's complete.
Is completed, and each aspect on the flowchart is discussed from one team to the next.
Correct.
Yeah.
Exactly.
And the same thing happens again in the morning.
And it's kind of like your process when we have a whole clinic morning rounds.
That's right.
When we've got our process of all the patient identification and of what's happened with it.
Yeah. Ultimately, as your surgical service grows and your caseload or your volume of surgeries that you perform grows and your team grows, there's increasing pressure to put in place these structured communication processes and checklists and structured job descriptions for each person's role in the treatment of the patient. Everybody knows what's going on.
Yep.
And really, what you have to do is get to a point where all of your team are more or less on an equal plane. Everybody has a voice. Everybody contributes. Checklists, can't talk about them enough. But even though they feel a little bit like role-playing and sort of a little awkward when you start them,
You'll begin to love them, and you'll learn to love them.
Yes, because they just double check, and they give you that quiet time before you start a procedure to make sure you've got it all right.
Correct.
And there's nothing worse than medical error. I mean, the outcomes are always horrible.
We all feel awful when something does happen. So.
Yeah. And essentially have that attitude of, the more people involved in the care, the more people thinking about the care, the better their outcome. And remove that attitude of a mistake was made by an individual and that individual is bad and, they should be punished. It's not. Lots of little errors occurred along the way, and then the Swiss cheese lined up, and then the medical error occurred.
Exactly.
Yeah. All right. Well, thank you everyone for tuning in, and I hope today's episode was useful. And we'll certainly see you all again, I expect. I think Jess might come back for a bit more.
Oh, we'll see.
All right.
Excellent.
Well, that's a wrap.
Thank you.
And that's a vet wrap. Join us fortnightly for these podcasts. You can access them through our YouTube channel, our Vet Education Hub on the Peninsula Vet Care Emergency and Referral Hospital website, and all other platforms that you can source your podcasts.